Good evening. I want to welcome everybody to this week's Sagis Dermpath Happy Hour session. As always, if you have any questions during the presentation, feel free to place them in the chat and I'll be kind of monitoring that. Alternatively, you can always email us at education@sagisdx.com, or you can email me directly, tdavis@sagisdx.com. Before we get started with tonight's session, I wanted to let you know, if you don't already, that we're going to be hosting a board review for the upcoming Dermpath core exam. The session, the answers for our board review will be discussed on Saturday, October 22nd, between 12 and 3. Dr. Yala, my colleague at Sagis Diagnostics, and I will be running the session. The format will follow similar to the other board reviews that we've done. The session will be recorded and posted on the YouTube channel shortly after the discussion is complete. You should be able to view it within a day or so. And a link will be sent out to those people who pre-registered or registered for the board review. So if you're interested, please go to the Sagis Diagnostics website and go ahead and register for that board review. Well, it's a real pleasure for me to introduce our host for tonight, Dr. Jennifer Vickers. Jennifer has hosted our sessions in the past. Jennifer is board certified in dermatology and dermatopathology. She currently splits her time between seeing derm clinic and reading dermatopathology for her group. She's an excellent educator, was on the faculty at Dell Medical School before her current private practice move. So it's a real pleasure for me to introduce Dr. Jennifer Vickers. Jennifer.
Hi, everyone. I am Jennifer Vickers. I am a dermatologist and dermatopathologist in Austin, and I'm one of the pathologists at Sagis, which is how I came to be here. Dr. Davis asked me to join you guys for happy hour this week, and I'm always excited when he asks me to do this. I think it's a lot of fun, and I used to teach. So this gives me an opportunity to teach a little bit more. All right, so I'm going to go ahead and share my screen, and we'll open this up. Hopefully you guys can see this. This is our first one. Let me get us oriented. So this is a nice punch biopsy. And from low power, you can see that there is inflammation there. It's both superficial and deep. So there's not a lot going on in the epidermis from what I can tell. There is just a normal stratum corneum. The epidermis itself looks like it's just hanging out. Nothing too exciting there. So all of the action is apparent in the dermis. And so we want to look at the pattern of the infiltrate as well as what kind of cells we can see. So let's kind of dive in a little bit. And I'm starting to see what looks like some histiocytes, lymphocytes, overall just a mix of cell types, but predominantly lymphocytes and histiocytes. And the pattern that I'm seeing is something called palisaded. So palisaded is when you have radially arranged infiltrates of inflammation, and they're usually surrounding something. So here we go, radially arranged here. And we want to see what's in the middle of those to help us determine what is going on. So in this case, I'm seeing like some sort of like blue fluffy looking stuff. There's definitely some histiocytes in there, maybe some fibrin, but the majority of it is not fibrin, maybe some collagen and elastic fiber degeneration. But again, that's not really the predominant feature, but I do see blue fluffy stuff there, and that stuff is mucin. And if you're having difficulty seeing the mucin, you can always do a stain like a colloidal iron or Austrian blue to see that mucin. And when you have the radially arranged inflammation around those kind of collections of mucin, that is characteristic of something called granuloma annulare. So it is called granuloma annulare because you have this granulomatous inflammation, and clinically it is annular in appearance. So oftentimes it can get confused for ringworm, but differences being clinically that ringworm, you have some surface change, there's usually some scale, and overall, it just looks a little bit different than we'd expect for GA. For GA, like I said, all the action is in the dermis. So you have more of an infiltrated look. You have more of like a dermal lesion. I don't know how else to explain that. Typically they're raised, not a lot of surface change. It just has some substance to it. And it's arranged in an angular pattern like a ring. So that's why it's oftentimes confused with ringworm. So this pattern is nice to recognize on a test. Occasionally you might get a little bit harder pattern here where the histiocytes are just sort of kind of creeping along through the collagen and you don't really see that palisaded pattern. But for the most part, you're going to see the palisades and you can call it GA. All right. Oh, I didn't mention, so when it is kind of sneaking through the collagen and you don't have the palisaded pattern, histologically we call that interstitial GA. Let's go to number 2. And get you oriented here. Looks like a shave. First thing I notice is that the epidermis is very acanthotic, so it's very thickened. It's blue. I see some pseudohorn cysts, so my first thought might be, it kind of looks like a seborrheic keratosis, but it's a little bit more endophytic in nature than what I typically see with a seborrheic keratosis. And you kind of have these fingers going down into the dermis, and that's, that's endophytic pattern. And if we get up and close here, you start to see that the keratinocytes are making this sort of whirling looking pattern. Those are called squamous eddies, and they're getting a little bit glassy. Still pretty blue, not really pink and glassy, but a little more glassy than we typically see with these this whorled pattern or these squamous eddies. We can see that happen in seborrheic keratoses when they are irritated, when they've been rubbed or inflamed. And in this case, with it being more endophytic, it has a special name. A lot of people think these are probably just a variant of an inflamed seborrheic keratosis, but we call them an inverted follicular keratosis, or an IFK. So when we call it that, what we're indicating to the clinician is that it is very likely that clinically these things look like they could be squamous cell carcinomas. They are maybe very hyperkeratotic. There's a little more substance to them because they're going down into the dermis. And even histologically, they can be confused with squamous cell carcinomas, except that we don't see a lot of atypia. And like I said, it's a little bit more blue. So it looks like a seborrheic keratosis, but it looks like a very irritated seborrheic keratosis. And so we specify these as IFKs, or inverted follicular keratosis. Let's move on to number 3, another punch. All right, so honestly, not a lot going on here. You might think, why am I looking at this? Maybe some very sparse, scant perivascular inflammation, not really a lot. You could say that the epidermis is a little bit more papulated, maybe a little bit hyperkeratotic. And so when you see something like this and you think, what am I looking at? I don't see anything going on here. In essence, it looks kind of normal. One of the things you're going to want to think to do is to dive in and look at the stratum corneum. And in this case, it will pay off, because if we dive in and look at the stratum corneum, we start to see things here that shouldn't be there. And these are little fungal elements. So in a dermatophyte infection like T. corporis or ringworm or T. pedis, you have fungal elements, little hyphae in the stratum corneum, but oftentimes they're difficult to see. They're not as blue as they appear here. They're often pink. And so you have to use a PAS stain to kind of highlight them. You can see them with the naked eye here and there, but really they're highlighted with a PAS. In this case, these fungal elements are very readily visible, and they're more, like I said, more blue in color, and they have different morphologies that you can see. So here we have one that's kind of like a shortened hypha, and then you have like the little round fungal elements. And so we like to refer to these, just because we love to talk about food and dermatopathology, we like to refer to this as spaghetti and meatball pattern. And this is pretty characteristic of Tinea versicolor or pityriasis versicolor. So you guys may already be very familiar with the clinical findings with this. It tends to be on the chest and the back. It is caused by, we think it's caused by an overgrowth of yeast, particularly Malacessia. And there are different types of Malacessia that contribute to this. So it happens oftentimes in the summer when people get kind of sweaty. The yeast there have a lot of food to eat because they eat our sebum. and they get overgrown and they start to create these little macules that coalesce into patches. One clue with this one, although it's difficult to say because I don't know the patient's baseline pigmentation, but it's called tinea versicolor because it can change the color of the skin. And in some patients, it's hypopigmented. In some patients, it's hyperpigmented. Some patients, a little more erythematous. But you see a little bit of some pigmentation at the basal layer here, and that could be secondary to what's happening in the stratum corneum, or it could be that this patient just has a little more pigment at baseline. It's hard to say, but that can be helpful sometimes. So pretty easily treated, which is the good news. We just fight off the yeast. We kill off the yeast with different anti-yeast medications. It can recur oftentimes in the summer, but like I said, not harmful to the patient and easily treated, so not a huge deal. A little bit fun to find these on histology, especially if you think to look. That's the big thing. You have to think to look in the stratum corneum, and sometimes that's not an easy thing for me to remember either. So if I'm looking at something and I'm like, what is this? Why am I looking at this? It looks normal. Dive into the stratum corneum and see if you can find any clues. And like I said, in this case, it paid off. All right, moving on to number 4. I don't even really have to get too close here for you to see what's going on. There is a split occurring here. And when you have a split, clinically, that's going to look like a vesicle or a bulla. And when you're thinking about bullous disorders, you want to think histologically what level the split is occurring. So in this case, it is occurring at the level of the dermoepidermal junction. It's almost like the epidermis is a hat that's being lifted off. And so the dermis is just kind of, it's left behind. It's just hanging out. So one thing I want to point out, this is not a great example of it, but it can happen. And the reason I want to point this out is when I was learning dermpath as a resident, we learned about something called festooning. And that occurs when the epidermis lifts off of the dermis and the sort of undulating pattern of the dermis is left behind. And you can sometimes get these little out pouches called festoons. And I think some of us had started to believe that that was associated with very specific diagnoses, and it can happen in lots of different diagnoses. So you can see it in this diagnosis, which we'll talk about here in a second, but you can see it in other diagnoses as well, where the epidermis is lifting off. Okay, so back to our split. This is a subepidermal split. You have some festooning, and within the blister cavity, we see some inflammation. So we want to go in and see what kind of inflammation this is. Seeing some lymphocytes, but what's really sticking out to me is all of these pink cells, all of these eosinophils, and there are quite a few of them, and they're hanging out in that blister cavity, but they are also lining up right at the dermoepidermal junction. And that is characteristic when you have all of these things put together. You have a subepidermal split. You have these eosinophils in the blister cavity. You have eosinophils in the dermis. So if I move up a little bit, you're going to see them all in the dermis here. You can see them around the blood vessels, but also just within the collagen. And then you see them lining up at the dermoepidermal junction. You should be thinking about bullous pemphigoid. So bullous pemphigoid happens in older patients, typically like 70s, 80s, although it can happen in younger patients, particularly if it's drug-induced. And if it's caught earlier, it's biopsied early, it can be in like its plaque stage or kind of urticarial stage. And in that case, you don't have blisters yet. So you're not going to see the split that we see on this case. You'll just see this infiltrate of eosinophils, and you might think it's like a hypersensitivity reaction. You might think it is urticaria, but eventually the patient is going to start to develop the blisters. As a pathologist, you really want to be thinking about that as a possibility when you see those findings. But luckily in this case, we do have our split, which tells us a little bit more about what's going on. You would also want to encourage the clinician to get a DIF just to really solidify that diagnosis. And but you can tell them with pretty good confidence that that's what's going on, and those eosinophils are really key to figuring that out. All right, so moving on to number 5. Let me turn this. Another punch. So first thing I'm noticing is that there are really large sebaceous glands. So that can give me a clue about location. And as I've told told many people this in lectures that I've given. When I used to teach, I used to tell my residents this: use all of your clues. So if you have something that gives you an idea about location, that oftentimes can give you another clue as to what's going on in terms of the diagnosis. So remember, we talked about, well, we'll get to that one, but in this case, lots of sebaceous glands. And so this is probably located on the face. I'm also seeing these sort of nodular aggregates of inflammatory cells, and particularly of lymphocytes. There's some histiocytes in there, some plasma cells in there as well. And they seem to be sort of gravitating towards the hair follicles. So kind of perifollicular inflammation, nodular aggregates of lymphocytes, large sebaceous glands. And then over here, and I'm going to show you another piece that shows more of this, you see some dilated vessels within kind of an edematous stroma. If I move up to this other piece, you have a great example of that. Let me get up there. Here we go. Big, big dilated vessels here with some edema kind of surrounding those. So clinically, I want you to try to imagine what this patient probably looks like. You have dilated vessels, so they're probably red, or they may even have some little telangiectasias or little dilated vessels. It's on the face. It's inflamed, very, very inflamed. This is probably starting to look more like a papule, almost like an acneiform papule perhaps, but without a pustule in this case. So inflammatory, redness, dilation of vessels, all of these things on the face, all of these things are pretty characteristic of rosacea. So that's what this patient has. So we don't really think of that as being all that interesting clinically. Lots of people have rosacea. We know how to treat it. But histologically, it can look pretty interesting. And then within the pores, within the hair follicles and the pores, you may even see some little demodex mites that are just hanging out there. They like to eat the sebum as well. So a lot of us have mites hanging out in our face. People get really grossed out by that, particularly patients. But we don't really know what role those mites play in rosacea. We do know, however, that there seems to be a correlation between higher levels of those and people with rosacea. It's pretty straightforward there. Moving on. Probably a shave. The epidermis looks a bit thickened, does not look normal. First thing I'm noticing is that the color isn't normal. It's probably kind of angry appearing. Let's get in here and see what's happening in the epidermis, and definitely not normal. So normal epidermis might look like, let's see if I can find some normal epidermis. Might look like more like this. There's probably some spongiosis here, but the cells, the keratinocytes look pretty normal. And then you get down to this other piece, not normal. So you have these huge cells. They have lots and lots of cytoplasm. Sometimes it's eosinophilic, sometimes it's more basophilic. They have vesicular nuclei, and they are starting to kind of aggregate at the bottom of the epidermis, but they're also starting to scatter up towards the upper layers of the epidermis as well. And there is a word that we use to describe that, and it's a pretty good clue about what's happening here, and it's called pagetoid spread. So you can see that in melanoma in situ. You can see that in a squamous cell carcinoma in situ, and you can see that in Pagets disease, which is where pagetoid comes from. And Pagets disease looks just like this. So you have these pagetoid cells, or these Paget cells, that are just large and kind of very irregular, acting up. I'm seeing a lot of mitotic figures throughout the epidermis here, which is also a clue. Lots and lots of mitotic figures. It can sometimes be difficult to distinguish Pagets from a melanoma in situ or from an SCCIS. In this case, not so much, but there are stains that you can do to differentiate those, and I won't really get into that today. But if you see these huge cells that are kind of making their way towards the top of the epidermis and have this pagetoid spread, those are the things you want to be thinking of. So keep that in the back of your brain when you see something like this. This looks like it's probably extramammary. I don't think this is breast. Mammary Pagets is almost always, I believe, associated with an underlying malignancy. Extramammary definitely can be. It doesn't have to be, but it can be. So if you see this and your patient gets diagnosed with this, you want to start trying to figure out if there's an underlying malignancy that's being missed. So just kind of burn that into your brain. Okay, moving on to number 7. We can see that there's definitely something going on here right away. You have this large tumor in the dermis. And we're going to go see what's happening here. So the cells appear spindled, comma-shaped. In some areas, I saw they were kind of more wavy. You can't really see that so much here. They're very bland. You know, nothing, they're not pleomorphic, they're not different sizes, very bland cells. There's sort of this mixoid appearance to this as well. And what we're seeing is a nerve that is sort of being infiltrated by these spindle cells. So this is a mix of Schwann cells, it's a mix of fibroblasts, and the appearance of it is very similar to just your run-of-the-mill neurofibroma. And so that clues you into what's going on, but this is a little bit, it goes a little bit beyond just a typical cutaneous neurofibroma. This is a plexiform neurofibroma, at least that's what it looks like. So you have these kind of nodular pattern here, multinodular in a lot of cases. So you see lots of different nodules. And clinically, the kind of buzz phrase that we use is bag of worms. So you can imagine that this, this is going to have these bulky nerves, and they're going to be snaking through the collagen, through the dermis. And so it feels and looks like a bag of worms. But looking at the infiltrate itself, I mean, it looks like a neurofibroma. A little more myxoid here. So these are all characteristic of a plexiform neurofibroma. That can be, often is pathognomonic for neurofibromatosis type 1. People can have plexiform neurofibromas and not have NF neurofibromatosis type 1. It doesn't happen often though. So when you diagnose this, you basically are giving the patient that diagnosis. So you want to be sure that that's what's going on. You want to get some clinical history from the clinician. When you have the plexiform type, you can also see like a cutaneous neurofibroma just kind of hanging around at the periphery that doesn't necessarily involve the nerve, but you kind of see it throughout. Moving on to number 8. This looks like a little shave. Immediately, you might notice these big dilated spaces that sit just under the epidermis in the superficial dermis. And these spaces are lined by endothelial cells, which do not appear to be atypical, and they're thin-walled, and they can kind of anastomose with each other, like you're seeing here. And you might think to yourself, well, this is probably just a hemangioma. I have these dilated vessels here. But we don't see erythrocytes within it. At least we don't see many erythrocytes in it. What we see is more of like this wispy-looking stuff, and that is lymph. Because this is a lymph malformation, it's a lymphangioma, and clinically it's going to look like little translucent or clear, kind of bubbly looking papules that can be in clusters. And the buzzword that I always learned as a resident is it looks like frog spawn, which I always thought was kind of gross. But clinically they're pretty recognizable, but maybe it wasn't that day and the clinician did a biopsy, or they just wanted to solidify their diagnosis. This is what you would see under the microscope. So big dilated spaces that are anastomosing, thin-walled, lined by endothelial cells that are not atypical and often full of lymph. Now, sometimes you don't see the lymph in there, but you definitely don't want to see a whole lot of red blood cells like what you would see in hemangioma. The next one is also one of my favorites. Before I get into high power, I just want to look at this at low power and start talking about some clues here. So this looks like it's probably a pretty meaty, meaty specimen. It's got a thick dermis, it's got a lot of sub-Q fat, and within that sub-Q fat, we have these big terminal hairs. But I want you to notice something here. We have terminal hairs on this side, and we have terminal hairs on this side. We do not have terminal hairs within the central portion here. So you can start to imagine that clinically, that central portion might be bald, no hair there. So start thinking about things clinically where you might see some, like a patch of balding. And then the second thing I'm noticing here is all of these big sebaceous glands that are sort of just lining the dermis, sitting right under the epidermis and just kind of going right across the whole specimen, which you wouldn't typically see. You definitely would see sebaceous glands, but you would not see this many, and they probably wouldn't be this prominent. You might notice that the epidermis looks very papillated. It's undulating, so clinically it's going to look bumpy. So bumpy and bald, and then you have all these sebaceous glands, and it's on the scalp. So putting that all together, you can conclude that this is a nevus sebaceous or nevus sebaceous of Jaddison. So nevus sebaceous, they occur in kids. In kids, they're often not as noticeable. They're smaller. They might be a little bit yellow in appearance. What the parent's going to notice is that there's no hair there. They're going to ask you about it. But when that child, particularly a male child, hits puberty, these sebaceous glands, which are sensitive to androgens, start to enlarge, and this thing can get very warty and very papillated, and frankly, not very appealing looking. And so patients oftentimes want them removed. And that's a good thing because we recommend removing them in a lot of circumstances, mostly because they tend to grow other things. A nevus sebaceous itself is not worrisome, but over time they can start to grow things. They can grow basal cell carcinomas. One of the most common things that they grow is syringoadenoma papilliferum, which if you haven't learned that already, you will. It has very distinct pattern, very fun to say. So syringoadenoma papilliferum, that's one of the most common things that grows in nevus sebaceous, but also basal cells, also trichoblastomas. I don't know if this has changed because it's been a while since I took my boards and it's been a while since I was in residency, but we often were asked the question on our practice exams and our regular exams, what the most common thing is that grows within a nevus sebaceous. And at that point, it was a trichoblastoma. For a while, it was that syringoadenoma, syringocystadenoma papilliferum. Those were thought to be the most common, and eventually it changed over to trichoblastoma. Double check that, but make sure you know what is currently the most common thing that is thought to grow within these. And I said syringoadenoma papilliferum, but it's syringocystadenoma papilliferum. Needed to correct myself there. I didn't think that sounded right, but I kept saying it incorrectly. So that's what that is, syringocystadenoma papilliferum. And like I said, if you don't know that one yet, you will eventually. Okay, guys, we are on the last one. Number 10. And this looks like it's probably just a little papule, probably dome-shaped. Looks a little bit like a skin tag, maybe not as pedunculated as you would expect a skin tag to look like. You might be thinking about like a seborrheic keratosis. But within the dermis, when we get up closer, you see that it's much more cellular. And you have all of these fibroblasts. Sorry, I'm having difficulty with my Zoom here. You have all of these fibroblasts, so all of these kind of spindle cell looking cells. And you also have some that are stellate, and some that are large and kind of bizarre looking, and some that really are kind of boring looking, and they're all over the place. And so that is called pleomorphism, when the cells aren't really looking like each other. You have some that are big and some that are small and some that are atypical and some that look boring. That's pleomorphism. That can sometimes be a bad sign, meaning you see that and you think, something, something sinister happening here. And you start to look for signs of things misbehaving. So do you see any necrosis? Do you see any mitotic figures? And in this case, I don't. It actually looks like it's behaving other than the fact that you have all of this pleomorphism and all of these little weird looking cells. In this case, this is called a pleomorphic fibroma. And clinically, it might just look like a little skin tag, just like a little papule. And it's much more interesting histologically, again, because when you first see it, you're like, what is happening here? There's all these bizarre cells, sometimes these monster cells. But at the end of the day, they're all minding their own business. They're just making this little pretty picture for you. And I don't see any signs of something more sinister happening like the necrosis and the mitotic figures. So kind of burn that into your brain, pleomorphic fibroma. This one can be a fun one because it can be easily recognizable also. Okay, guys, well, that concludes our potpourri for today. Thank you for joining me. I hope that you guys got something out of this. If you have any questions, please shoot it our way. And Dr. Davis or myself will be happy to answer it. And hopefully you guys learned a lot, and I hope you have a good rest of your week and that you have a wonderful Monday as well. So I'm going to go ahead and stop sharing my screen and exit out of this, but thank you so much. Have a good rest of your week.
Thank you, Jennifer. And again, if anybody has any questions, please feel free to shoot them our way. Hope everybody has a good evening. Thank you.